we will be invited to revisit different biomarkers present in peripheral blood, other fluids that can provide cues to neuropathological components and prognosis. We had today in the opening session the presence up here on stage of Pascual Sanchez-Juan, Scientific Director at Fundación CIEN. We will have Pascual moderate this last session. Welcome back, Pascual. Enjoy.
Thank you very much. Okay, I think the first session in the morning were perfect to give us an idea of the complexity of what we are facing. I'm clinical neurologist, so all these things have been basically under the radar of we clinicians, and now we are starting to really being able to make more precise diagnosis, but we just use very limited palette of biomarkers. Basically, in the clinic we do CSF or PET to rule out Alzheimer's disease, but we still have very important challenge, as you have seen. Co-pathology is really the norm, not an exception. We have to be aware of co-pathology. We've been talking about resilience, especially we will talk with Mark. When you want to really do a preclinical diagnosis, you have to really have into account co-pathology, resilience of the brain. All these things are really complex, and with neuroimaging, as we saw, we only can infer secondary effects, which is fine, but probably with fluid biomarkers we can go a bit deeper, trying to get the molecular etiology of some of these pathologies. So we're going to have three panelists. I have to say that Professor Anja Schneider told us that she's not feeling okay. So she may be able to connect, but we don't know. So we will see. Let's see that she's okay and she can connect. But we will start with Gemma Salvadó. Gemma Salvadó is a rising star in the field of biomarkers. She's currently working in Lund University in the biomarker study, so she's in the forefront of the discovery of biomarker, and I cannot think in a better person to give us an overview of this very dynamic field. So Gemma, the floor is yours.
Thank you very much for the kind introduction, and I would like to thank also the organizers for this very nice meeting that we have now, and for inviting me to present. So I will talk a little bit about the current status of fluid biomarkers, and here I will mainly talk about blood biomarkers, but a little bit also on CSF. So I would like to focus on three main topics that we are interested in Sweden, in Lund, and it's how do we apply these biomarkers in the research context, but also more importantly, the clinical context, and how do we use them for clinical trials, which I think is the future of Alzheimer's disease right now. So let's start with the research context, and we're going to start with a very easy correlations with one of our favorite biomarkers, plasma p-tau217, which we here correlated with amyloid plaques and tau tangles in a neuropathological cohort. And as you can see here, this biomarker correlated very nicely with both pathologies. And this can be, of course, good, but at the same time, it shows us that this is not very specific biomarker of tau pathology, although it's called p-tau. And here we try to assess the contribution of different pathologies, the plaques and tangles, in these different biomarkers in this neuropathological cohort. And one of the most interesting things is that we saw that there is a very strong association or contribution from the amyloid part on these levels of p-tau markers. So it seems that we're still missing one biomarker that is specific of tau pathology, or tau aggregated pathology, to be more specific. But there seems that we are going there. In this study, in collaboration with Washington University, they developed and we validated this CSF MTBR tau243, which is the biomarker that we are showing here, and that correlated very nicely with tau PET pathology measured in PET, sorry. And this was significantly a stronger association than the one that we can see with the other very nice biomarker p-tau217. And here we can see again that this MTBR showed the highest betas in correlation with tau PET, both in the Biofender study, but also in our replication cohort in the NIGHT ADRC. In both when we consider all participants, but also interestingly, when we only consider the amyloid positive. And if we do again this similar analysis in which we look at the contribution of these different pathologies, we see that MTBR is mainly explained by tau pathology here in the bars in green, whereas the other p-tau markers that we had here are showing the same that we were seeing before, a more or a high contribution of amyloid pathology shown here by the long blue bars. So it seems that, as we were saying, that MTBR is more specific of tau pathology, whereas the other p-tau biomarkers are more amyloid. And then we have here the p-tau205, which seems to be a little bit in between these two pathologies. So seeing that these different p-tau markers and MTBR are related to different pathologies of Alzheimer's disease, we assess whether we could use these different biomarkers for staging Alzheimer's disease, looking at different, as we know that different stages of the disease are related with the abnormality or the accumulation of different pathologies. So in this study, we use 5 different CSF biomarkers, including amyloid, p-tau217, p-tau205, MTBR, and a non-phosphorylated tau. And we saw that we could develop this CSF staging scheme in which each biomarker, the abnormality of each of these biomarkers was defining the next stage. First, the amyloid, then, as I said, the p-tau217, and the rest of the biomarkers. And here we can see how this is defined in the putting all these 5 biomarkers together. And here, just to mention briefly, this was done in a data-driven approach, so we didn't force the model to find these stages. It's the stages that came from the data. Interestingly, when we look and we compare these CSF stages to other biomarkers of AD, we also saw what we could expect. So early abnormality in amyloid PET, later abnormality in tau PET, and then cortical thickness, NFL, a marker of atrophy, and neurodegeneration, sorry, and MPAC, a marker of cognition, to be more abnormal at later stages of this CSF staging scheme. And maybe more importantly, we also saw that these CSF stages could have a prognostic value, as they were also associated with the longitudinal accumulation of these different pathologies, but also the progression from cognitively unimpaired, or MCI, to Alzheimer's dementia, with these stages 4 and 5 in red being more prone to progress in a shorter term than the ones in earlier stages. But as we have seen today, it seems that not everything is amyloid and tau, and many other things can happen together with these pathologies. So in this very nice study by Alexa Pichette-Bennett, she investigated using proteomics how different proteins were abnormal or were differently expressed in different stages of the disease. And here we, we define the different stages basic in the AT criterion. And as you can see here, some expected proteins like MAPT was elevated in the A plus T minus participants compared to those that were A minus T minus. And also, interestingly, we found the smoke one, and maybe what is more interestingly is that these proteins seem to change depending on which stages we are comparing across the disease continuum. But again, as I said, not everything is amyloid and tau. So Ines also is doing a similar study, but in this case, looking at the vascular copathology. And here she looked at the white matter hyperintensities, microbleeds, like Hunes, and other biomarkers that we can see in the MRI. And she also investigated the different altered proteins compared to this kind of lesions. And as you can see, she finds a very differentiated kind of proteins depending on the lesions that we see. And very interestingly, also, these seem to be related to different types of cells in the brain. So more to dig into of the pathophysiology of the disease. And now we are moving a little bit more into the clinical context. This is an aspect that we are very interested in Sweden, and is how we can move from these very nice studies that we're seeing here to the real patients. So in this first study, what we did is to compare plasma p-tau217 to the FDA and EMA approved CSF biomarkers to assess amyloid pathology. And what we did here is to compare how good these biomarkers were, how good p-tau217 was in comparison to these CSF biomarkers that are now currently done in the clinical practice. And the gold standard here to assess amyloid pathology was amyloid PET. And as you can see, the plasma p-tau217 had very high accuracy, very high PPV, NPV, and sensitivity, reaching levels of 90%. But of course, missing 1 out of 10 participants is still not good enough for the clinics. So we use this two cutoffs approach that Wagner and others have developed, that is as easy as doing 2 different thresholds, one for very high pathology and one for low. And then we have 3 groups, one with high probability of having the AD pathology, one having low probability of having AD pathology, and then an intermediate group that we still don't know exactly what is happening to them. And then this could be the ones that we further assess with a CSF or a PET, or we follow them more closely in the future. So applying this kind of approach, we did the comparison again, and we see that, again, plasma p-tau217 was very good, and here we increased the accuracy up to 95%, which I think it's the most that we can ask for. And it was not significantly different from the CSF biomarkers. And also, interestingly, the intermediate group was only was below 20%. So we are saying that we can accurately assess 80% of the participants with a plasma biomarker and then follow this 20%. But of course, this is research, and everything is very controlled. So what happens if we go to the real world? So this is a study, I think a very nice study led by Sebastian Palmpins, in which we look at plasma biomarkers, and here is the p-tau217, but also the APS2 score, which mixes both p-tau and A-beta 42/40. And we look at how these biomarkers work in secondary care. And this is really taking all the patients that go into the clinic and assess them with the plasma biomarker and comparing to other CSF biomarkers or amyloid PET that they were doing in routine. But still, this is not good enough. Well, we can see here that the accuracy and all the statistics are very good, around 90%. But this is still single batch analysis, meaning that we collect all the plasma and then we send it and we analyze it in a single batch. But real world is not like this. So we did also prospective analysis in which we collect data, send it to analyze every 15 days. So it's more what it would happen in the clinical routine. And we saw that changing these different kits or the different set of analysis didn't change the accuracy, which was still pretty high at 90%. But we, or Sebastian, went a little bit more, and he also did this analysis in primary care individuals. So people that went really into the doctor, just saying that they had problems in cognition or because of the family. And they also found that this accuracy was really high. And just for comparison, here in light blue and gray, we have the dementia specialist. We are comparing the plasma biomarkers to the dementia specialist and to primary care physicians to assess this AD pathology. And as you can see, it seems that plasma biomarkers are doing quite well in comparison to them. And finally, just here as a note, of course, if we did this two cutoffs approach again, this accuracy and specificity increased a little bit up to almost, 95%, while again having less than 20% of the participants in this intermediate group. But of course, this is, we use here a mass spec plasma biomarker, which which takes a lot of time and takes a lot of energy. So in this nice study done by Noël Vermeulen in PhD in our lab, she compared different assays of plasma p-tau217 to CSF biomarkers and look at the accuracy of assessing amyloid PET positivity or tau PET positivity. And she found that indeed, as expected, the mass spec biomarker here, the WASHU one, was the one that had the highest accuracy. But then there is still also some high accuracy and some Simoa platforms that were similar or even higher than some CSF biomarkers that are used currently. And I'm going to finish with fluid biomarkers for trials. And here I'm not saying about assessing how they track the disease progression in trials, but can we select participants better for doing these trials better and try to see really what is happening in their brains? So this is a study led by Niklas, and based on this idea of the donanemab trial, in which it seems that the best results were observed in these participants that had some tau pathology, but not so much. So selecting this kind of population would be maybe better for clinical practice. So thinking on that, and that we cannot do amyloid and tau PET to all individuals that come into the clinics, he used plasma p-tau217 to assess this group. And he used, again, this two-threshold approach to separate those with low tau, in which there is no enough pathology for the treatment to happen, to those that have too much pathology and maybe it's too late for them, to select this intermediate group that we are interested in this kind of trials. And showing this kind of approach, he also found that the scans saved could be up to 40 or 60% using only plasma biomarkers. But this is in cognitively impaired individuals in which we know that the prevalence of amyloid pathology is quite high. What happens if we go to an earlier population with the prevalence is lower in cognitively unimpaired individuals? So here we are doing this study in which is a collaborative study in which we propose to do a two-step approach again, but doing two different sets of biomarkers. First, a blood biomarkers, and if you have a low risk, then you continue, you don't do anything. And then if you have an increased risk of amyloid positivity based on this blood biomarker, you either do a CSF analysis or a PET scan to do an invasive test to really assess this high or intermediate low risk of amyloid positivity. As I said, this is a collaborative study with 13 independent cohorts. And here you can see the PPV, so the positive predictive value, or how we can trust a positive result. And we see that plasma biomarkers here in red seem to have a similar positive predictive value than the PET when we compare to the CSF. But when we do this second step, we increase a lot the PPV, so we can be really sure that even in this early population, those participants have amyloid in their brains. And now we are talking about pathology, but also in clinical trials it's important that people not only have pathology, but that progress during the course of the clinical trial, of course, because we need to see a difference between the placebo and the drug. So here in this study, Rick and Alexa showed that even having a smaller amount of tau pathology in PET in the middle temporal lobe in green had a survival effect, so these persons progress more quickly than those that only had amyloid or that had no pathology at all. But as I said before, doing an amyloid and tau PET scans to everyone is not possible at this time. So in this next study, what we did is, again, to see whether we could do this with plasma biomarkers. So here, again, with a collaborative study, we compare the plasma biomarkers to assess cognitive decline and progression to mild cognitive impairment in blood, to tau PET in the middle temporal lobe and the temporal area. And we saw that the plasma biomarkers seem to do a pretty good job comparable to the MTL tau. And in this next analysis, what we did is, can we do this again, this two-step approach in which we first do a plasma analysis and then a PET to assess how much this person will progress into the disease? So it seems that the answer is yes. So here we did this two-step approach, and maybe here is more obvious. We try to assess how many people we could decline we could lower the number of participants at the initial stage of the trial by only using plasma up to 37%. But if we further do some PET analysis into these participants, we can reduce the sample up to 11%. And with that, I'm gonna move quickly. This is a study in which we went a little bit more early, and here in cognitively unimpaired participants without amyloid pathology at baseline, we observed that being positive in plasma p-tau217 and amyloid beta 42 to 40 in plasma showed the highest slopes in amyloid PET accumulation. So it seems that we can still, we can already select those participants that are going to accumulate amyloid with these two blood biomarkers. And just to finalize, and just not to talk about amyloid, here, these are some studies of our work, of our group, about the presence of Lewy bodies co-pathologies. And here we showed that both in cognitively impaired and cognitively unimpaired, the presence of both AD pathology, but also Lewy body pathology in pink, had a significant steeper slope in cognition. And this was also reproduced by Lidwin in the ADNI cohort here in the group in purple. So to summarize, We have seen that different biomarkers are related to different pathological aspects of the disease, which might be useful for different objectives, meaning the diagnosis, prognosis, or understanding the disease. Also, that AD biomarkers have to be properly validated to be ready for the imminent change in the clinical setting. And of course, we have done some studies on this, but more is needed with a more heterogeneous population. Finally, biomarkers, I think, are key to investigate the earliest stages of the disease, which I think is the next step of the AD field. And with that, I would like to say that biomarkers for AD are the present, but also the future in diagnosis, prognosis, patient management, and trials development. And with that, I would like to thank all the BioFunder group and all the funders, and thank you for your attention.
Thank you. Thank you very much, Gemma. I think we will leave the question for the last part of the session, and I have a very good news because Professor Schneider is feeling well enough to connect and give us her talk, which I think is going to be really, really interesting. I think Professor Schneider, she works in Bonn University, and I think she has published one of the most exciting papers in the field of biomarkers this year. We've been talking about TDP-43, the importance of TDP-43